Hi, MRINMAY.
Hi Nadeem, good evening.
Good evening. Sorry for the confusion.
No, not at all. It is my mistake. I did not read the note. I was just took it for granted at the usual time.
Yeah, actually, it is always the usual time, but there was an IAPM lecture between 7 to 8, so they requested that we should just push it half an hour back. So I thought, let's do that.
Okay, perfect. No problem at all.
So, should we start? Are you ready?
I am ready, absolutely.
Yeah, fair enough. Right. Good evening,
still
everybody.
It is 2 minutes to 8. Okay, no problem. Yeah.
Yeah, I think by the time we'll be up on. Okay, fine. Let's wait for a minute. No issues.
Yeah, I think.
Okay, just give me a minute.
8.
Yeah,
take your time.
Yeah, just give me a minute. The net is a bit slow, so just give me 1 minute. So we'll start?
Yeah. Let's start.
Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue. Now we are streaming live from Kuwait City via Kolkata. In the beginning of this month, we had a lecture on the FNAC of Pancreas, session 1, in which Dr. MRINMAY had dealt with the PSC system of reporting and the multimodal diagnostic approach in cystic lesions. This is session 2. And here he'll be talking about the FNAC of pancreas, the solid lesions. Dr. MRINMAY MALLIK He's an MD from PGI Chandigarh, a consultant cytopathologist from Mubarak Al Kabeer Hospital, Kuwait. He has been working there as a consultant for more than 2 decades and has been teaching graduates and postgraduate students in pathology, as well as laboratory technology. He's got many publications of his original publications in national and international journals. His areas of interest are cytopathology of soft tissue, thyroid, gastrointestinal tract, pancreas, along with human papillomavirus detection and genotyping in cervical cancers. Before I ask Dr. Mallik to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me ask Dr. Mallik, sir, please share your screen and let us start. Thank you so much.
Yes. Go to present now.
Yeah, I can see your screen. That's great.
Right, okay. Right, I think I will hide. Yeah, sorry. Good evening,
Please start.
everybody. And thank you, Nadeem, once again for a kind introduction. So, after the previous talk on the cystic lesions of the pancreas and the Pachynicolau system, in this particular webinar, I intend to talk about the solid lesions of the pancreas. Now, when I look at solid lesions of the pancreas, I like to look at these lesions in 3 groups, 2 major groups and a minor group. The first 2 groups are as follows. The group number 1 is a group of lesions under which we have pancreatic ductal adenocarcinomas, some interesting variants of pancreatic ductal adenocarcinomas, and mass-forming pancreatitis. In the next group, the members are pancreatic neuroendocrine neoplasms, solid pseudopapillary neoplasms, acinar cell carcinomas, and pancreatoblastomas. The remaining are the rare and remote lesions, which I am going to talk about at the last part of this webinar. So why do I like to look at the solid lesions in these 3 major groups? The reason is that if we look at the first group, which has been outlined in red, and the next one, which is outlined in blue, there are some features which bind them together. First of all, if you look at the imaging, the first group comprising of the ductal adenocarcinomas, the variants, and mass-forming pancreatitis, on imaging, what you see is an ill-defined lesion. Whereas in the other 4, you are going to find a well-defined lesion on imaging. Now, because of these imaging features, more often than not, the radiologist and the gastroenterologist will be able to give you a lead into which particular group of lesions you might be dealing with. The second reason why I like to group them as such is because the first 3 lesions in this group, the morphology is chaotic. So when you look at the smears, you get a feel of a sense of disorder. Whereas in these 4 lesions, what you are going to find is a sense of order among the cells that are there under the microscope. So let us see what I mean by that. So I have put 2 examples. The one on top is a PDAC, that is the abbreviation that I am going to use. The one below is a solid pseudopapillary neoplasm. Now, the fact which I would like to stress over here is that when you look at the picture on the top, you are going to find a sense of disorder, a very chaotic kind of appearance. Whereas if you look down, there is a more of a sense of order because of a more monotonous population of cells. So this is the reason I like to look at tumors in under these 2 major umbrellas. Along with it, of course, there is the cue which comes from the gastroenterologist, so it helps to set us on the right path. So let's begin with the ill-defined solid lesions. The two major groups in this particular group of lesion are the pancreatic ductal adenocarcinomas and their variants, and of course the mass-forming pancreatitis. So, what about the pancreatic ductal adenocarcinomas on fine needle aspiration cytology? A very important thing to remember is that they can show a wide range of morphological features, and that is extremely important. More often, in the same case, you are going to find an admixture of distinct morphological features within the same aspirate, which can be extremely helpful, and I shall tell you why. The architectural features can be extremely variable. There can be sheets of cells, there can be huge tissue fragments, there could be cohesive and discohesive clusters, and they can be very tight or they can be very loosely cohesive. Along with it, you will always find, almost always, a population of isolated cells. Now, when you look at these sheets or tissue fragments or even the clusters, a very important thing to remember is that there is going to be a disarray of nuclear orientation. And in those very well differentiated pancreatic ductal adenocarcinomas, when you have a problem in differentiating it from reactive conditions like in mass-forming pancreatitis, the single most important thing to remember is this fact, and that is the disarray of nuclear orientation. Then of course, another very important feature is anisonucleosis, which is a variable degree, which can be minimal, it can be dramatic, and it is said that if in one cluster you can see that the ratio of the size between the smallest nucleus and the largest nucleus is more than 1:4, that you are almost certainly dealing with a case of a ductal adenocarcinoma, taking into consideration the other features that you see. There are variable degrees of chromatin abnormality, and this is very important. You can have normochromatic cells, but you can have extremely hypochromatic cells. Of course, you can have hyperchromatic cells and cells with irregular clumped chromatin. The nucleolar prominence can be extremely variable. You can have very tiny nucleoli or no nucleoli, and you can have those very large prominent nucleoli staring at you. The cytoplasmic margins, usually sharp, giving the so-called drunken honeycomb appearance. They can even be wispy, sometimes they are opaque, and quite often you are going to find a bit of necrosis or karyorrhexis, which is admixed with these neoplastic cells. Now we looked at a number of our pancreatic ductal adenocarcinomas, and we did a kind of a detailed analysis, and would like to look at this particular article which is published in the Journal of Cytology this year, where we have done each and every feature of a pancreatic ductal adenocarcinoma. We have dissected the feature and you have presented them. You might like to take a look at them to see the variations in morphology and some of those same things. So first of all, what about architecture and arrangement? As I have said, you can have a variable array of architectures. Here, as you see, you can have cells in very large sheets and tissue fragments. You can have clusters which are very tight. You can have clusters which are loose. You can also have individually scattered or isolated malignant cells. As far as the sheets and clusters are concerned, this is the most important slide that you should remember. Here we see that the nuclei, they're pretty hypochromatic or normochromatic. They really do not strike you as malignant at the very beginning. But the most important thing to see over here is look at the way the nuclei are arranged. The polarity is completely deranged, and the sense of total disorder if you look at the long axis of the nuclei. So this is what is meant. So this is a perfect picture to drive in the concept of what is the meaning of an array of disarray of nuclear orientation within a sheet or a cluster. And if you see a cluster or a sheet like this, you can be almost certain that you are dealing with a malignancy. So this kind of a disarray of nuclear orientation is extremely useful in coming or arriving at a correct diagnosis. Now, what about an isonucleosis? So here you see a variation in an isonucleosis, the two extremes here. There is not much of an isonucleosis between the cells, little bit of irregularity which should guide you. But look at the isonucleosis over here. Look at these cells and look at these cells, and they're lying side by side, a concept of what has been put forward as the concept of a dramatic anisonucleosis. So when this is present, it is extremely helpful. You know that you are dealing with a malignancy. Now, the variation in chromasia also can be pretty striking. Here the cells are hyperchromatic to normochromatic, very, very pale chromatin. And look at the chromatin over here. It is extremely hyperchromatic. A very important point is that you may find the combination of all these features in the same case, sometimes even on the same slide. So, if you are struggling in making a confident diagnosis of malignancy based on certain sheets or clusters, if you just move around, you are going to find some other areas where you can be more confident in making a diagnosis of malignancy. So that feature of pancreatic adenocarcinomas, which you have seen over and over again, is the mixture of features within the same case can be extremely helpful in arriving at a correct diagnosis. Now, this is what is meant by drunken honeycomb appearance, with the cells are distended, clear. They have very sharp borders looking like the cells of a honeycomb. And this is another place where you see these sharp borders, and this is what is meant by drunken honeycomb appearance. And when you see a drunken honeycomb appearance and you are trying to differentiate it from something like chronic pancreatitis, this is a very, very useful finding. This is another picture, a higher power or closer look as a drunken honeycomb. As you can see, this is very, very sharp borders. And when this is present, it is very helpful. You see, otherwise, the nuclei look pretty sharp outlines. You are going to hesitate to call this malignant. But when you see this kind of features, this drunken honeycomb pattern, it is extremely useful and it will help you give a diagnosis of malignancy. Sometimes you may find features of perineural invasion on cytology smears, and once in a while, very, very rarely, you can have a very dense neutrophilic infiltrate admixed with malignant cells. Now, there is a variant of pancreatic ductal shows a very dense neutrophilic infiltrate. These are anaplastic, undifferentiated anaplastic carcinomas with rhabdoid features. They are characterized by INI1 loss, but in this particular case, we could not do the INI1 to say that whether it is one such case. But yes, if you find pancreatic ductal adenocarcinoma with a lot of neutrophils, this is one of the things which you should keep at the back of your mind, consider, and if possible, run the INI1 and see if it falls into that category. But I'm going to talk about it in detail a little bit later on. Now, we have to also remember that endoscopic ultrasound guided FNAC can play an extremely important role in the staging of pancreatic ductal adenocarcinomas. This is an aspirate from a celiac lymph node, where you see the lymphoid cells admixed with clearly malignant cells. Now, you should always be aware of gastric epithelium, because if you keep a particular figure at the back of your mind of drunken honeycomb, and if you know that pancreatic ductal adenocarcinomas, the well-differentiated ones, can be very bland looking, it is quite possible that one might just see a sheet like this, see a little bit of overlap, and think that am I dealing with a very well-differentiated ductal adenocarcinoma? You are not. Because in this case, the cells are pretty well spaced out, that is fine. Nucleus is normochromic, that is pretty okay. But what you see over here is this mucin cap. Okay, so these are gastric cells, this mucin cap. Okay, so these are gastric cells, and if you go to other parts of the fields, you are going to find these cells which are actually the gastric parietal cells which are admixed. So this can be a trap. Please remember that when you go through the body of the stomach, there's a very good chance that you're going to aspirate gastric epithelium, and they can have a drunken honeycomb appearance. So we have to keep that at the back of our mind when dealing with these aspirates. Now let us look at some of the variants of pancreatic ductal adenocarcinomas. So I'm going to start with a case from our own archives. This particular case was reported almost 3 years ago, and we found this extremely pleomorphic population of cells, okay, with very pleomorphic nuclei and abundant amount of opaque kind of a cytoplasm, and this is the cell block, right? And so look at this multinucleated, and this is actually a tumor giant cell, not the osteoclastic kind of giant cell which we are going to talk about a little bit later. And so we did a cytokeratin, and it turned out to be positive. We called it an undifferentiated carcinoma of the pancreas, anaplastic subtype. So, according to the WHO, the undifferentiated carcinoma of the pancreas, they are classified as follows. You can have undifferentiated carcinoma of pancreas with osteoclast-like giant cells and the rest. So this is one particular category. It's very important because this particular category has a different kind of a biological behavior. They are usually of a much better prognosis compared to the others. These are very poor prognosis. So undifferentiated carcinoma anaplastic, like the one I showed you in the previous slide, there is a sarcomatoid variant of undifferentiated carcinoma which resembles a sarcoma. There is a carcinosarcoma which shows a mixture of carcinomatous and sarcomatous areas, and there is a rhabdoid kind of an undifferentiated carcinoma which shows rhabdoid cells. Now, I do not have slides from our departmental archives for these cases, so I'm going to show you some pictures from what I have got from studies that have been published online. So, this is the first one, the undifferentiated carcinoma with osteoclast-like giant cells. So, these tumors have a population of osteoclast-like giant cells along with the population of other cells which are smaller, but they could still be highly pleomorphic. So it is an admixture of numerous osteoclast-like giant cells with a population of highly pleomorphic looking cells, some of which are tumor giant cells. And interestingly, in most of the cases, if you move around, you will find areas of conventional pancreatic ductal adenocarcinomas. The osteoclastic giant cells are positive for CD68, whereas in the other cells, which are the non-osteoclastic giant cells, you are going to find focal positivity for pancytokeratin. Some of them can even show CD68 positivism. The INI1 is retained in these cases. These tumors have a better survival than conventional pancreatic ductal adenocarcinomas. The next one, I have not come across any FNA report of a primary undifferentiated carcinoma sarcomatoid type from the pancreas. So this is a picture of a report of a histopathology of the same lesion. So this is pretty straightforward. You are going to find this areas of lesions which look like a sarcoma. They turn out positive on cytokeratin, which means that any case of a pancreatic tumor which looks like a sarcoma, you have to run a cytokeratin. Vimentin can be focally positive. So these tumors have an extremely poor prognosis. This was from a report published by Zhao et al. In the World Journal of Clinical Cases. Then another case where I do not have an FNA, but you can look at the histopathology, and by looking at it, you can extrapolate these findings and imagine what it might be on cytology. So we have got a carcinosarcoma with sarcomatous areas, carcinomatous areas. You can see the cytokeratin is positive in the malignant gland, negative otherwise. In the other areas shows a reversal vimentin positivity. So this is an article published by Royce et al. And then the pancreatic undifferentiated rhabdoid carcinomas. In 2015, the Agiemi et al. Have described and have differentiated them into two separate subtypes. Subtype number 1 is the one where there are gene alterations of KRAS in the form of mutations and amplifications. These cases have their INI1 retained. The other group do not show any alterations of KRAS, they're wild type KRAS, but there is INI1 loss. There is a kind of a morphological correlate because the one where the INI1 is retained show very pleomorphic giant cells, and that is what is the dominant cell population. Whereas the other group where there is the INI1 loss, it is far less pleomorphic and it shows a slightly more, it's really not right to say monotonous anaplastic cell, but it is not as pleomorphic as the other group of KRAS gene altered INI retained undifferentiated carcinomas. And as I mentioned a little while ago, this may show a very rich infiltrate by neutrophils. Of the other important immunohistochemical finding, almost all of them show E-cadherin loss and many of them show loss of beta-catenin. Right, so these are two pictures side by side. To the left is the one where INI1 is retained and to the right is the one where INI1 is lost. As you can see over here, this tumor appears to be far more pleomorphic, really ugly looking cells as compared to this tumor which does show pleomorphism but has a more monotonous pattern. And here you see that there is a very rich admixture of neutrophils. So they show two different morphological patterns which can be very useful if you are to face such a case under the microscope. You have to of course run the immunohistochemistry and if possible, if you have the facilities, the molecular test to look for KRAS mutations. So what are the major differential diagnoses of undifferentiated carcinomas? I think it is very intuitive: sarcomas, melanomas, anaplastic lymphomas, metastatic carcinomas with extremely undifferentiated features, metastatic adrenocortical carcinomas. I'm not going to go into the immuno, but you can just imagine you have to resort to immunohistochemistry to sort out such diagnostic dilemmas. Right. This is one of our cases. This is a variant which is called a foamy gland carcinoma. It shows, instead of the typical cytoplasmic features which you see in pancreatic ductal adenocarcinoma, where there are very sharp margins, here you can, the cells, they have a very kind of a fragile cytoplasm. That's why giving them the name foamy gland adenocarcinomas. Sometimes the nuclei can be extremely bland looking, and as a result of which, because of this kind of deceptive features, they might even be missed. So one has to be very, very careful in looking at, when you are looking at this lesion, not to miss these lesions, right? And sometimes, if you are able to do a cell block, this is what you are going to see of glands infiltrating through a desmoplastic stroma, abundant amount of foamy cytoplasm, and there are the nuclei. And you can see some amount of hyperchromasia and irregularity in the nuclear outlines. This, of course, is an MGG picture. If you are looking at the pancreas, since pancreas is a very common site for metastasis of renal cell carcinoma, I'm sure RCC is going to come into your differential diagnostic table. Of course, you can use immunochemistry. For example, you can use PAX8, which is almost never positive in pancreatic ductal adenocarcinomas. CK7 can be of great help because pancreatic ductal adenocarcinomas CK7 positive, CK20 negative. Anyway, whereas the classic kinds of RCC which comes in the differential diagnosis over here most often are CK7 negative. This is another of our cases, which is a pancreatic ductal carcinoma with this huge, humongous vacuoles, which is called the so-called vacuolated cell variant of pancreatic ductal adenocarcinoma. Then we have a SIGNET ring cell carcinoma, where on histopathology the cutoff is to have more than 50% of the cells should be SIGNET ring cells. Important thing to remember is that these tumors may have a very rich admixture of acute inflammatory cells. The other one which we spoke about are the pancreatic anaplastic carcinoma with rhabdoid features. So this is another group of tumors which can have a very rich admixture of acute inflammatory cells hiding the neoplastic cells, thereby delaying the diagnosis or giving rise to mistaken diagnosis. Mucinous colloid carcinomas are tumors where you have abundant amount of extracellular mucin, more often in the background of previous intraductal papiromucinous neoplasms. Now, one very interesting fact is that the production of MUC2 is highly specific in colloid carcinomas because most of the ductal adenocarcinoma, whatever mucin they have, is MUC1, and they have been shown to show better survival figures compared to the usual PDACs. Next, pancreatitis. One must remember that this can be a major pitfall. Okay, so whenever you are reporting pancreas FNA, you have to always give this, that you are always under the sword of pancreatitis, because this could really be very difficult, one of the biggest pitfalls of pancreas. Why? Because certain inflammatory conditions may mimic pancreatic ductal adenocarcinomas on imaging, and the ones which are very well known to do so are the mass-forming chronic pancreatitis, focal autoimmune pancreatitis, the paraduodenal groove pancreatitis, and obstructive chronic pancreatitis with diffuse ductal dilatation and diffuse pancreatic atrophy. These are more of the terms here used by the radiologists, and they have got specific connotations, and they know that when they are making the diagnosis, they have a chance of undercalling or overcalling these lesions. So I am just going to talk about the first one in details on cytology and a little bit about the other one. Mass-forming chronic pancreatitis, okay, they account for about 27 to 50% of all, sorry about the spelling mistake, chronic pancreatitis present with a localized mass, and the CT may allow accurate differentiation in about 77% of the cases. So they need the FNA to get to the correct diagnosis. Autoimmune pancreatitis, just relevant facts with regards to cytology is as follows. Autoimmune pancreatitis, mainly types 1 and 2. The type 1 is diffuse. It is associated with extrapancreatic disease, diabetes, and have raised serum IgG4, so it is easy to diagnose. It is the type 2 lesions which are problematic, present mainly with focal mass-like lesions. Their extrapancreatic autoimmune features are extremely rare, except for IBDs, which may be found in about 30% of the cases, and most importantly, they may have normal serum IgG4 level. And to add to the confusion, rarely some adenocarcinoma patients may show raised IgG4. So what about the cytology of chronic pancreatitis? So this is what you see. You see these little clusters of cells, sometimes larger sheets of cells. There is a bit of a discohesion, some bare nuclei, things breaking up. You start getting a bit uncomfortable. Am I looking at some kind of a discohesive cluster of adenocarcinoma? The nuclear margins look pretty okay, normochromatic. So this is kind of a picture of chronic pancreatitis. You may have a little bit of necrosis in the background, some stromal fragments. So this is what chronic pancreatitis look like. If I look at this, I'll say that no, this is most likely a chronic pancreatitis, and I'll go with chronic pancreatitis. I would possibly not even call it ATYPIA just on these fields. So this is fairly consistent with what we see in chronic pancreatitis. Now, another picture of chronic pancreatitis, you see that the cells are just breaking up, some naked nuclei, little bit of kind of a degenerated material in the background. This is a GIMSA, so slightly enlarged nucleus. Okay, so this is more or less what you see in chronic pancreatitis. But what about these features? Here, I start getting a little bit worried. Why? Because if you look at the sheets of cell, this is beginning to show areas of disarray. But here in this area, as you can see, there is a kind of an order. Here starts getting a little bit of disorderly, but again it maintains a bit of an order over here. So I start getting a bit worried, but still I am not going to call it an adenocarcinoma. Maybe I'll just put in a word of caution, say that it's possibly a little bit of ATYPIA, maybe suspicious. So I'm going to show you another one. Let's look at this one. So here there are three pictures. In the middle is something which should guide you. This is exactly what a benign pancreatic ductal epithelial cell should look like. So this is absolutely normal. Absolutely pleasing look, monolayered sheet of cell, no overlap. This is just kind of a fold, normochromatic, very sharp nuclear outlines. As you move to this side, what you see is that there is a significant amount of disorder, right? But you see some neutrophils admixed here and there. Nuclear margins are extremely sharp. So I am not very sure. I am going to put in a word of caution. I'll say possibly there is a pancreatitis, possibly there is some amount of atypia, maybe even go suspicious on this. This one looks, on the first glance, looks almost like this, but this is the one where I am almost 100% certain that we are dealing with a pancreatic ductal adenocarcinoma. And the reason I am so certain is because of the disarray. If you look at the nuclei, you see there is absolutely no order in the nuclei anywhere. Look at the nuclei here, how they are arranged. Look at the nuclei here. Okay, so there is a kind of a windswept kind of an appearance, total nuclear disarray. And this is what I'm looking for. This is what I rely on the most to call something a pancreatic ductal adenocarcinoma. So that is the reason I just wanted to put the three pictures side by side, just to give you a sense of what's happening here. So, okay, once more. So, this is a benign ductal epithelium with possibly a bit of reactive changes. Here is what I am 100% certain. I can sign out this as a pancreatic ductal adenocarcinoma because this is what nuclear disarray looks like. Chronic pancreatitis with atypical suspicious features continued. Here again, you have got little bit of a nuclear disorganization, some but very sharp nuclear margins. And when you have this kind of an infiltrate where only the ductal cells are infiltrated by neutrophils, this is more in keeping with a benign chronic pancreatitis rather what we find in malignancy. What I spoke about, this very heavy neutrophilic infiltrate with malignant cells, that is a totally different picture. Here you have a smear in which you have these sheets of cells and only within the sheets you have got infiltration by neutrophils. So this is most likely chronic pancreatitis. Here again is chronic pancreatitis with little bit of disarray, some degree of nuclear enlargement, some overlap over here. I might go and put in a word of caution and say it is either atypical or suspicious. Keep the patient under follow-up or just look at the imaging and come to a decision of what to do with the patient in the subsequent times. Right. So what are the four features which I find most useful in difficult cases? I've just put them together in a single slide. I've been mentioning this over and over again. Number one is nuclear disarray, as you see over here. Honeycombing. This is very useful. You usually do not see this kind of honeycombing in chronic pancreatitis. Look at this nuclei over here, washed out chromatin. Chronic pancreatitis will never show you this kind of a washed out chromatin. This is a kind of a chromatin which reminds you of something like a papillary carcinoma minus the grooves at least. So this is a very, when you see that in pancreas the chromatin is very clear, it is extremely helpful in pushing you towards a diagnosis of pancreatic ductal adenocarcinoma, apart from the fact that of course you can see the anisonucleosis, you can see that how the nuclei over here seems to be jostling for space, right? So they are crowded, some open, they're separated in one place, crowding together in another place, again a sense of a disarray apart from the chromatin, and of course you look at this kind of an extremely irregular nuclear outlines. If they are present, they are very useful. Always look for dual cell population. For example, if I have to show you this particular slide, if you look at the sheet of cell over here, there is definitely an element of disarray. Okay, but some of you might not be very, very confident in calling this as am I dealing with a chronic pancreatitis? Am I dealing with a well-differentiated ductal adenocarcinoma? Well, with looking at this kind of nuclear features, I think that the amount of disarray is pretty okay with me, but I get more confident when next to this I find these cells which are obviously malignant. Okay, they have a honeycomb appearance. Look at the nucleus, look at the irregular nuclear outline, and look at these cells over here. So, and look at this cell just coming out of this particular sheet. So a dual cell population can always help. So even if you have a few clusters that mixed with this, it helps you pull the trigger and call it a ductal adenocarcinoma. The other thing which we have realized is that cell block sections can often come to your rescue in very difficult cases. This is from a very recent case where I was not very sure whether we are dealing with a pancreatic ductal adenocarcinoma, chronic pancreatitis, and then we come across this. Most of the glands we're looking at, these are most likely benign glands, and then in between we have got these glands about which I have absolutely no doubt that they are malignant. Cell blocks can also come to your rescue in situations where the tumors are extremely desmoplastic, and on smears you hardly see any malignant cells. You should always do a cell block. In fact, in our hospital, the instruction that has been given to the gastroenterologist is to collect most of the material as needle rinse aspirates for cell block, because I can tell you at least maybe 7 to 10% of our cases we have where we would not be able to give a diagnosis of adenocarcinoma if we didn't run a cell block. And this would be one such example. Look at this. So it's very desmoplastic, and in between you have got these cells. These are malignant cells which are just running through little spits and bits, right? And they would not come in the aspirate. And we then did the cytokeratin, and you can see these cells are cytokeratin positive. So cell blocks can be very helpful even in paucicellular aspirates. So what about the role of immunochemistry in differentiating between chronic pancreatitis and PDACs? So the three things which is considered to be very useful are S100P, MASPIN, and IMP3. If they are positive, especially if you are using a combination of them, it is extremely helpful in pancreatic ductal adenocarcinomas because the benign conditions are usually negative. So if you have a combination of them, at least two of them, or even one of them, it's obviously going to reduce the sensitivity. It is very useful. Remember that MASPIN is positive in the squamous metaplastic areas of benign ducts. That is a good, important thing to keep at the back of the mind. People have used SMAD4 loss, but it is present in 60% of PDACs, so 40% of them are not associated with a poorer prognosis. P53 positive in 50 to 55% of the cases. And remember, CEA may be positive in 40% of pancreatic ductal adenocarcinomas. This is a very recent, it was published in 2018 by Antibopa et al., showing the diagnostic role of S100P, IMP3, MASPIN, and PVHL in differentiating diagnosis of pancreatic ductal adenocarcinomas. Would like to might take a look at this paper. Now, it's time to go to the circumscribed solid lesions, and these are the four which I've already spoken about: pancreatic neuroendocrine neoplasms, solid pseudopapillary neoplasms, acinar cell carcinomas, and pancreoblastomas. Now, what this particular slide shows you the four different lesions, and it is extremely difficult to tell one from the other because all are characterized by a very monotonous population of cells, and that is the reason I like to consider these four lesions together. Of course, there are ways by which you can differentiate between them using light microscopy as well as immunochemistry, but generally they look the same. So if when you have a population of cell which under your microscope looks like this, immediately these four lesions should come to your mind. So what are these four lesions? Let us see. The first one is a pancreatic neuroendocrine neoplasm. This one is an acinar cell carcinoma. This one is a solid pseudopapillary neoplasm. This one is a pancreatoblastoma. Let's start with pancreatic neuroendocrine neoplasm. The key points are as follows. They're categorized according to the 2017 WHO classification. You should know what that is when you are reporting cytology, although you may not be used it completely, and I shall tell you why. Some easily recognizable cytological features help us to say, okay, we are dealing with a pancreatic neuroendocrine neoplasm. We are going to see some pictures. But there are these major mimics, the three of them which I just spoke about, you should always remember. You should know that there have been attempts at grading these tumors on FNA material. I'm going to talk about that. And they do have a number of variants. So pancreatic neuroendocrine neoplasms look very straightforward, but they have a number of tricky morphological variants which are rare, but we should be aware of them. So the 2017 WHO classification of gastropancreatic neuroendocrine neoplasms, what it did is that it divided them into actually three groups, but we are only going to first talk about these two. The well-differentiated neuroendocrine neoplasms, WDNENs, and poorly differentiated neuroendocrine neoplasms, that is PDNENs. So what are these? The well-differentiated neuroendocrine neoplasms are divided into G1, G2, and G3 based upon the Ki67 index and mitotic counts. And these are the counts which are used as cutoff to differentiate between these three lesions. The poorly differentiated neuroendocrine neoplasms, as you can see, the Ki67 index and the mitotic count exactly the same. So, what is the difference between neuroendocrine tumor NET G3 and a neuroendocrine carcinoma G3, which can be of two types, the small cell type and the large cell type. The small cell type is a typical small cell carcinoma that you see in the lungs and you see in other parts of the body. The large cell type is a typical large cell neuroendocrine carcinoma. The basic concept is, if a tumor fits into the category of a small cell carcinoma or a large cell neuroendocrine carcinoma based on the pleomorphic features, based on the necrosis, based on the other features which you associate with small cell cancers, you call them small cell neuroendocrine carcinoma. So what is a neuroendocrine tumor G3? This is a tumor which you are going to call a well-differentiated neuroendocrine tumor based on the morphological features. And then it comes or creeps into this grade of G3 because of the Ki67 index and because of the mitotic count. And there, of course, there is another group of neoplasm called the mixed neuroendocrine, non-neuroendocrine neoplasms, MRINMAY or MANEX. I have a slide for that a little bit later on. So first, let us get the concept of this versus this out of the way. Okay, so before that, another point. What about the gradings of pancreatic neuroendocrine neoplasms on FNA? Now we know that the therapy and the subsequent management of pancreatic neuroendocrine neoplasms according to G1, G2, G3 depends on the counting of Ki67 index and the mitotic count performed on surgical resection specimen, because there are some very, very strict criteria which we have to use in order to do the count. So, we have to count 50 high power field in high density areas, divide the number by 10 to get the mitotic count per 10 high power field. Or for the Ki67 proliferation index, it is based on the evaluation of greater than 500 cells with areas of higher nuclear labeling or so-called hotspots. Right? Now this is done on surgical resection specimens. However, there have been studies listed here that have tried to reproduce the above on cell block sections with varying degrees of concordance between FNA and surgical specimens for the above counts, and both undergrading and overgrading have been considered to be issues. So it's not fully accurate, and as a result of which, although it is very tempting to take up the challenge of grading these tumors on FNA, because of the fact that it has strong prognostic implication and because of the fact possibly in the future it might have impact in decision making before you go out and do the surgery, at present In order to do G1, G2 and G3, you need surgical resection specimen, and as a result of which we'll go back, when you talk about pancreatic neuroendocrine tumor, we use the word well-differentiated neuroendocrine tumors on fine needle aspiration cytology. We do not do G1, G2, G3. Some people might like to do it, give a kind of a vague count, because this has not been set well to be able to confidently say what it is, because it is all about mitotic count. So either you are going to call it this group or you are going to call it this group. So what is the concept? What about a well-differentiated NEN versus poorly differentiated NEN? So this is a well-differentiated NEN. Okay, so this is a well-differentiated NEN. Look at the plasmacytoid cells. Okay, eccentric located nuclei, perinuclear HOF. We are absolutely certain that we are dealing with a pancreatic neuroendocrine neoplasm. Here, we are dealing with a small cell carcinoma. Both of them in the same particular group, but so the mitotic count over here, it doesn't really matter. You are going to use the mitotic count later on surgical specimen. So this is the base. So when you see something like this, we call it a well-differentiated NEN. Whereas if you see something to your right, you are going to call it a neuroendocrine carcinoma, small cell type. Right. Now let's look at some of the well-differentiated NENs, highly cellular smears. This is a low power, and this is what it looks like on the higher magnification, the typical salt and pepper chromatin. You've got this plasmacytoid nuclei. You are absolutely certain that we are dealing with a neuroendocrine tumor. You want to confirm, you can do a synaptophysin or a chromogranin, which turns out to be positive. Very good. But can we try? Has there been any attempt to differentiate between grade 3 neuroendocrine tumors versus neuroendocrine carcinomas? Some people have used immunohistochemistry, okay, because neuroendocrine tumors or well-differentiated neuroendocrine neoplasms, they exhibit loss of DAX and or ATRX, while the neuroendocrine carcinomas show abnormal P53, retinoblastoma, and loss of SMAD4. Now let us look at some variants of well-differentiated neuroendocrine neoplasms, which are very, very important. This you have seen in the previous webinar. 10% of pancreatic neuroendocrine neoplasms can be cystic, so they come in the differential diagnosis of cystic tumors. There is a group of pancreatic neuroendocrine neoplasms which are oncocytic. They are very rare, they are supposed to be very aggressive, but the most important thing is that because of these features, some kind of overlap of nuclei and other features, some prominence of nucleoli, this is really a cell block, they are likely to be misdiagnosed as pancreatic ductal adenocarcinoma. This is from an article by Chen et al. Sometimes pancreatic neuroendocrine tumors can be extremely pleomorphic. They can show bizarre nucleus. They usually do not have a prognostic significance, but if you just aspirate a few of these cells and you see this very, very bizarre nuclei, you may make a mistaken diagnosis of an anaplastic carcinoma or a pancreatic ductal adenocarcinoma, so keep that in mind. There is a variant of neuroendocrine neoplasms which are pigmented neuroendocrine neoplasms. The pigment is neuromelanin and lipofuscin, which is positive for mesoinfantana, susceptible to bleach. It is one of the diagnostic pitfalls of calling this a melanoma. However, if you keep this at the back of your mind, when you are looking at a pancreatic tumor on FNA and the tumor shows a lot of pigment, one should not jump into a diagnosis of melanoma immediately. If you do, the markers, cytokeratin and neuroendocrine markers are going to be positive, whereas HMB45, MART1, SOX10, S100 are going to be negative in this case. So this, if you remember this, you're not going to make a mistake. Then there is a group of pancreatic neuroendocrine neoplasms, which like many other organs, so spindle cells, this is one of our cases, showed a lot of spindle cells. We thought that possibly we are dealing with a GIST, so we did a CD117, we did a DOG1, everything turned out to be negative, and we did a synaptophysin, chromogranin, they were all positive. So you have to use appropriate ISs. When you're dealing with a spindle cell tumor in the pancreas, one of the differential is a neuroendocrine neoplasm. You have to do the appropriate antibody tests. Then there is a lipid-rich or clear cell pancreatic neuroendocrine neoplasms. So 50% of pancreatic neuroendocrine neoplasms, von Hippel-Lindau syndrome, are of this type. They can be sporadic. It contains lipid and glycogen, possibly a bit of mucin. The DDs are foamy macrophages, clear cell actinic cell carcinoma. They all come into the DD, pancreatic ductal adenocarcinomas, and of course METs. You have to use immunohistochemistry. This is another article by Richmond et al. Where they have described two very rare variants published in Diagnostic Cytopathology. One is the pigmented variant, which I showed you, and this one is the lipid-rich variant. And very recently, by Gambella et al., there has been an article which is an amyloid-rich pancreatic neuroendocrine tumor. Okay, they are more commonly associated with beta cell-derived pancreatic neuroendocrine tumor. They show scanty to moderate cellularity. So this is very important. So when you're doing the FNA, you see very few cells with a few aggregates of plasmacytoid cell block can come to your rescue. You see this kind of a deep eosinophilic amorphous material, and there it is diagnostically difficult because of the low cellularity. You have to remember other causes of low cellularity in pancreatic FNA, including fibrotic pancreatitis, IgG4 related sclerosing pancreatitis, which I've spoken about. Sometimes solid pseudopapillary neoplasm can have fibrosis, and in myeloma cases, rarely there can be deposits of amyloid in the pancreas. So you have to keep this rare lesion at the back of your mind when you come across dense homogeneous acellular material on pancreatic aspirates. Then the mixed adeno-neuroendocrine carcinoma called MANX. You can have tumor with both adeno and neuroendocrine tumors. It is a tumor with a mixed adenocarcinoma neuroendocrine differentiation where each component is at least 30%. And it has a poor prognosis with a biological behavior which is more like of a pancreatic ductal adenocarcinoma than a neuroendocrine tumor. And this is one of the very rare case reports of MANX. And I think there has been another series of a few cases which I couldn't find by Kazi et al. From Japan, in which they have shown, you can see the cell block. You see that some of the tumors are chromogranin positive, the others are not. So this is a mixed adenocarcinoma. Okay, next, the solid pseudopapillary neoplasms. They have a preference for young women. There are rare ones in men at older age group. They can be solid or partly cystic lesion. I have mentioned that in the previous webinar. It can be cystic. They're of uncertain malignant potentials. They're categorized as benign others in the PSC system, just like the well-differentiated neuroendocrine neoplasms. And there is a point mutation in exon 3 of beta-catenin gene is found in about 90% of the cases, which leads to the accumulation of beta-catenin. On FNA, you have highly cellular smears, but those with cystic degeneration can be hypocellular. You have got papillary fronts with fibrovascular size aggregates and acini. You have a fairly monotonous cell population, oval to round, with a wispy cytoplasm. This is very important, with ill-defined outlines. They can have cytoplasmic projections. The chromatin is fine and granular. Please remember this very closely. They can have frequent grooves, very important. There could be a lot of foamy macrophages and hyaline globules which are PS positive diastase resistant. Immunochemistry showed beta-catenin, nuclear positivity for beta-catenin, CD10 positive, vimentin, cyclin D, and I'm going to show you one slide when all these things will be dealt with in detail, comparing other lesions. They're negative for chromogranin, CA, and cytokeratin, can be sometimes positive, negative. The pitfalls is that they could have focal areas of synaptophysin positivity. Alpha-1 antitrypsin can be focally positive, and CD56 can be focally positive in a large number of cases. So this is what we look for, this capillary highways with cells coming out of it, and see the fibrovascular core. When you see something like this, your diagnosis is almost certain. Cell blocks can be extremely helpful to show you the typical capillary fronts. This is a Another high power view, as you can see here, the nuclei with they're very well defined margins and with fragile cytoplasm. Cytoplasmic margin is not very clear. Another view of a higher magnification, sharp outlines, normochromic, and these are some of the PS positive diastrin resistant globules. If you want to take a picture of what is the difference between the appearance of the nuclei, so this is an SPN on top, you can see the grooves, and you can see that the nuclei of neuroendocrine neoplasms have a fairly stippled kind of a salt and pepper chromatin, just to compare the morphology of these two tumors. So, beta-catenin, this is one of our cases, nuclear positivity, cyclin D1 can be positive. To add to the confusion, recently there has been a particular tumor has been described by Hua et al., which is the iron-1 deficient pancreatic undifferentiated rhabdoid carcinoma, which mimics solid pseudopapular neoplasm, and they have said they saw these features, and in spite of the fact that it was beta-catenin negative, the features to them were absolutely clear-cut, and I would have possibly done the same. But then when it was a surgical, when the specimen was removed, excised, they found out that they had areas which looked just like a SMARC deficient, iron-1 deficient pancreatic undifferentiated rhabdoid tumor, and here is the iron-1 loss. Acinar cell carcinomas are the next one. Their preference for men in their 5th to 9th decades. Half of them show liver mets at presentation. They have poor prognosis. They have cellular smears with a monotonous population. They have a delicate cytoplasm, very prominent nucleoli. They're positive for cytokeratin, trypsin, chymotrypsin, BCL10. Neuroendocrine markers may be positive in scattered cells. To call something a mixed acinar neuroendocrine, there should be more than 25 pitfalls, of course, is the above. And remember that more than 60% of neuroendocrine neoplasms, neuroendocrine tumors, can acinar cell markers. So this is a very, unless and until you're using acinar cell markers. So this is a very, unless and until you're using a panel. And focal alpha-1 antitrypsin positivity can also be found in these tumors. Acinar cell carcinoma, this is more of a classic picture of acinar cell carcinoma, where you have got a very monotonous population of cells with very prominent nuclei, okay, positive for alpha-1 antitrypsin and chymotrypsin from unit. But next, I'm going to show another case where we've tempered diagnosis of acinar cell carcinoma. They're very cellular, these cells are pretty discohesive. You see over here, the nucleoli are not that prominent. We do not have those cherry nucleoli as has been said in acinar cell carcinoma. But we wanted to do an alpha-1 antitrypsin, and look at this, it was strongly positive. So it means that there could be, and it was negative for chromogranin, negative for synaptophysin. It was, I think, and positive for cytokeratin. So this we called it as an acinar cell carcinoma. Next is pancreatoblastoma. It is the most common pancreatic tumor during infancy and early childhood. They have been very rarely reported in adults, but they have been associated with poor prognosis. So they show cellular smears with solid sheets, tissue fragments, and capillary codes, loose aggregates. There are 3 cell components. Apart from the mesenchymal cells, there are 2. The acinar cell component are round to oval, monotonous looking nuclei with a high NC ratio, smooth nuclear outline, and powdery chromatin. The squamate module typically show whirling, which is very important, with abundant amount of granular cytoplasm. The mesenchymal cells show cartilage. On immunohistochemistry, the acinar component shows trypsin positive, chymotrypsin positive, and alpha-fetoprotein positive. The beta-catenin here is nuclear, whereas the squamate component, it is positive for the cytokeratins 8, 18, and 19, and the beta-catenin is membranous and cytoplasmic. Most importantly, neuroendocrine markers may be positive in scattered cell in about 2/3 of the cases. So this is a pancreatoblastoma. About 12 cases in adults were published by Reed et al. And we had one pancreatoblastoma in our departmental archive almost reported like 17 years ago. I couldn't get it out. So I am showing you the picture from this study by Reed, which are the so-called acinar cells, right, round, scanty to moderate amount of cytoplasm, prominent nucleoli, and these cells here arranged kind of whorls. So these are the so-called acinar cells, where these cells here are possibly the squamoid cells, the squamoid modules with pale kind of chromatin and stuff of whirling. As you can see, a kind of a streaming pattern. So these are extremely important in arriving at a definitive diagnosis, apart from the presence of these blastema cells. So what about the use of immunochemistry to sort out the circumscribed solids? So when you are using immunochemistry for the circumscribed solids, what you have is that you have pan-cytokeratin. Pan-cytokeratin is going to be positive in almost all the cases. Even SPNs. Vimentin is going to be positive in SPNs, all SPNs. The others can be positive in neuroendocrine tumors, negative positive in others. We're looking at the next group of tumors, and these are the chromogranins, synaptophycins, and CD56. These are the neuroendocrine markers. They will be positive in neuroendocrine tumor, but SPNs can be focally positive. Adenoid cystic carcinoma can be rarely positive, and pancreatoblastomas can also show these cells. Next, what you have is beta-catenin, CD10, and cyclin D1. These are the tumors. These are the markers which are positive in SPN, but we have to remember that many of them can show positivism in neuroendocrine tumor. Beta-catenin neuroendocrine tumor is usually cytoplasmic, but those cases associated with familial adenomatous polyposis, those are the lesions which can have nuclear positivism. As far as beta-catenin is concerned, pancreoblastoma I have already mentioned. They show positive staining in the nucleus in the acinar areas, whereas in the squamous morules, they can show membranous and cytoplasmic staining. The CD10 is positive in the squamous morule. Regarding cyclin D1, I could not come across any particular reference to say whether they have any lesions in any changes in pancreatoblastomas. Alpha-1 antitrypsin, alpha-1 antichymotrypsin, and BCL10 are the main markers for acinar cell carcinomas. They can be focal, of course, in solid pseudopapillary neoplasm, so be very careful about it, and they can also be focally present in neuroendocrine tumors. So you have to use a panel. This should just serve as a guide. These are, of course, positive in pancreatoblastomas. BCL10 is again positive in acinar cell carcinomas. Alpha-fetoprotein positive, negative, positive, negative. So with this, I am going to end this particular webinar. There was another part which I wanted to add, but I did not add, and that was the part related to the rare and remote tumors, because we are running out of time. So I decided to just stick to this. But however, Nadeem, when I send you the PDF, or I'm going to send you another one, which is going to have the last part. So if somebody wants to look at that later on, that particular part, they can easily look at that. These are some of the other tumors.
We have time. We have time. You can continue. We have time.
Okay, so Nadeem, can you just give me a bit of time? I'll just give me like 30 seconds. Is it okay?
Yeah, please take your time. We have enough time. No issue.
Okay. Okay. All right. Okay. All right. Okay.
Absolutely fine.
I'll do that.
Absolutely. Yeah.
1 minute. Can I stop sharing the screen for a moment and come back in like 10 seconds, 30 seconds? Is it okay? Okay, no problem. I'll just come back to this. Okay, let me see. Solids. Okay. So, hi, Nadeem. Hello?
Yeah, tell me.
Okay, so these are some of the other tumors I just wanted to talk about. There are other lesions of note which one might come across. We could come across lymphoreticular malignancies, metastasis, melanomas, gastrointestinal stromal tumors, and malignant round cell tumors. So let us go through. So look at this particular set of pictures. You see a lesion which is extremely cellular, as a dispersed population of cells here, but over here the cells are aggregated together, right? So I would have a lot of problems in saying for sure that I am not dealing with an epithelial malignancy like, say, an acinar cell carcinoma, although it has a very dispersed cell population. So in such cases, what I am going to do, I am definitely going to do a cytokeratin, which I did, and it turned out to be negative. The next thing which I did was a CD20 on the cell block, and it turned out to be positive. So this is a non-Hodgkin's lymphoma. It turned out to be a diffuse large B-cell variant of a non-Hodgkin's lymphoma. But the important thing is that if you have morphological features like this, in lymphomas, you can have areas where the cells cluster together, looking like an epithelial malignancy, especially on smears. There are, of course, areas which can be very discohesive but very poorly differentiated acinic cell carcinomas, which acinar cell carcinomas can also have a very discohesive pattern of basis. So you have to keep this at the back of the mind. This, of course, is a more typical picture of a dispersed cell population in a non-Hodgkin's lymphoma. The next thing is, of course, the presence of metastasis. Pancreas are very frequent sites of metastasis. For example, if I look at this tumor, it will be very difficult for me to differentiate a primary pancreatic ductal adenocarcinoma or from a metastasis. This happened to be in a lady who was a known case of breast cancer. So they were suspecting a mets. And it was a single lesion in the pancreas, if I remember. And so what we did, we thought of the possibility. Estrogen receptor in this case was negative, but pancreatic adenocarcinomas can be estrogen receptor positive. This patient initially was GCDFP positive, so these tumor cells were also GCDFP positive. So we wrote a report saying it's consistent with a metastatic breast carcinoma. The next one is a metastatic serous carcinoma of the ovary, right? So this is what it was reported as, and I'm going to discuss some of the immunos. This is a metastatic RCC to the pancreas. This is a metastatic small cell carcinoma from the lung, because it was TTF1 positive. So it was a known case of small cell carcinoma in the lung. We ran a TTF1, which TTF1 can be positive in other small cell carcinomas, but not in small cell carcinomas in the pancreas. Primary small cell carcinomas of the pancreas are extremely rare. We have seen two, not primary, we have seen two small cell carcinomas in the pancreas. One was metastatic from, I think, the cervix, and one from the lung. This one was TTF1 positive. So immunos and MET, some points to remember. When you are dealing with a situation where you want to differentiate between a metastasis from the breast and a pancreatic ductal carcinoma, you have to remember that GATA3, if your favorite markers, we call a breast primary, may be positive in up to 60% of pancreatic ductal adenocarcinomas. And estrogen receptors can be positive up to 31%. And of course, there are these breast cancers which are estrogen receptor negative, so it could be a problem. Renal cell carcinoma, the classic RCC, useful. PAX8 can be extremely useful, so can be CK7, because pancreatic carcinoma CK7 positive, classic RCCs CK7 negative. To diagnose ovarian and uterine malignancies, use PAX8. I've tried to put things in a very simple way so that one can use it in practice. For lung adenocarcinoma, TTF1 and napsin is pretty useful because they are not positive in pancreatic ductal adenocarcinomas. For prostatic adenocarcinomas, very good. PSA and PSA can be very useful. No such reports of PSA in pancreatic ductal adenocarcinoma. But yes, there are some reports of alpha-methyl-CoA RAS-MES positivism in pancreatic ductal adenocarcinomas. Colon, remember CDX2 may be positive in a number of cases of PDAC, so you cannot use them. But the CK7, CK20 can be useful because pancreatic carcinomas are ductal carcinoma, CK7 positive, 20 negative. Usually, there can be other forms, whereas the colonic carcinomas, it is CK20 positive, CK7 negative. This is a case of a gastrointestinal stromal tumor. A gastrointestinal stromal tumor which you found in the pancreas, which turned out to be this. The top one is dog1, forgotten to label it. The bottom one is CD117. This is a very interesting case. I think this is the last case. There was a huge solid and cystic mass in a young female. The radiologist couldn't tell her whether it's from the pancreas, whether it's from the retroperitoneum. A very monotonous population of round cells. A lot of things were considered. However, it turned out to be positive for CD99. Later on, showed the typical changes on molecular pathology. This was a PNET which rose in the tissue around the pancreas. Many of the times, retroperitoneal mass lesions are targeted, and they are not really sure whether it is arising from the pancreas or from anywhere else. So that is it, I guess. So sorry for the, I thought that it might be getting a bit late, so I cut it down. So that is the end of my presentation. Thank you, Nadeem. As usual, thanks for your time. Thanks, everybody. Thanks a lot.
Thank you, MRINMAY. Wonderful presentation. Before I go and talk about the presentation, let me just first, take up some questions which are mostly on the YouTube. Would you be okay with the questions if I read them out to you now?
Yeah. Yes, sure.
Yeah.
I'll just
a minute, please. Yeah.
Take your time. Take your time.
Yeah, great. So I'll go one by one. The questions are there on the Google Meet chat. If you want, you can read them yourself. But for the benefit of everybody, I will read them.
Okay,
just to remind you once again that there is a 1 minute lag between Google Meet and YouTube. So maybe your answers would have another clarification from that end. So we might have to wait for a minute.
Yeah, sure.
So the first question is from Dr. Nabanita Das. She is from Assam, a very well-known pathologist there. She wants you to re-explain the drunken honeycomb appearance. It was not very clear to her.
Okay, I'll do so. Right. So I'll go back to my presentation.
Yeah, that's right.
Yes. So wait, just a moment. I'll go back here, and let me just go.
You have to start presenting now.
Okay, so resume your presentation. Resume presenting. I'm here.
Yeah, you are presenting now. Please share that screen. That's right.
I will share the screen. Yes.
Yeah, that's it.
Yep.
Perfect. Make it full screen. Yeah,
right.
Perfect.
So in a drunken honeycomb pattern, so what happens is you have the cells which are distended by the material which is inside, right? And there is a very sharp cytoplasmic outline, and the cytoplasmic margins of the adjacent cells, they abut on each other, thereby giving an appearance of a cells of a honeycomb. And because they are distended, it is the phrase which is used as a drunken honeycomb. This is one. This is another one over here, right? And I've got another one here. Look at this. So it reminds you of a honeycomb. So they are the nuclei, these are the cells, the cytoplasm, and look at the very sharp outlines. It reminds you of a beehive. So that is the reason it is called a drunken honeycomb appearance. And because this is not seen very frequently in the reactive conditions, it is of great help in helping in letting you go or move towards a diagnosis of pancreatic ductal adenocarcinoma. At the same time, I had shown another picture which is again a drunken honeycomb, but this is not a drunken honeycomb. So before you use drunken honeycomb, you have to ensure that you are not dealing with benign gastric epithelium, because you see here too, you have these cells, the gastric foveolar cells, and they're very sharp outlines, but this is, you have the mucin cap over here too to help you further. So, a drunken honeycomb, my experience, comes with this, or when it comes over here, in cases of pancreatic ductal adenocarcinomas. So this is extremely, because I'll just show you one more picture just to show you, because in the benign conditions, one moment. Yes, look at this. So, here you go. So you do not see those sharp outlines over. This is benign. This is a pretty reactive condition. You do not see those, even here you do not see a drunken honeycomb. It's not that you see drunken honeycomb everywhere, but when they are present, they're extremely helpful. Does that answer your question, Dr. Navanita? Hello? Hello?
Hello, yeah, can you hear me? Yeah.
Yeah,
Hello?
yeah. Yes.
Yeah, I think we'll wait for a reply. In the meantime, we'll go to the next question.
Yes.
Dr. Nabanita has another question. She says that she is a bit confused regarding the grading of the pancreatic neuroendocrine neoplasm.
Yes.
Regarding the counting and division.
Yes.
That is 50 divided by
Yes.
10. So if you could just go to that and just please speak on that again if you don't mind.
Okay. I'll just go to that in a moment. I might have.
That was in the first presentation. Pancreatic neuroendocrine tumor.
Was in the first presentation.
Yeah, in there. That's right. Yeah.
Yes, I'll go down. So it is per 10
Yeah,
high
there.
power field. So you do
Yeah,
50.
Just one slide above. Yeah, that one. Yeah.
Yeah, it should be, no, 50 divided by 5. This should be 5. I'm sorry. So
5,
50
okay.
divided by 5. Not, yeah, so she is right. Thank you. It should be
Yes.
5. It was a mistake. So
Fair enough.
50
So that is now
divided
clear.
by 5 to get to 10 high power field. Yeah, that's correct.
Perfect. So I'm just still waiting for Dr. Nabindita's response. We will go to the next. Dr. Susila Kudantapani. She is the head of pathology at the Basavataram Indo-American Hospital at Hyderabad. It's a very famous place. She's a very well-known pathologist, and she's an expert in bone tumor pathology. She says, very excellent pictures, sir. Your experience with immunocytochemistry in pancreatic lesions.
Right. So, when you talk about immunocytochemistry in pancreatic lesions, the most of the times we use immunocytochemistry is for the second group of lesions. That is the circumscribed solid lesions. They are extremely helpful in differentiating between the solid pseudopapillary neoplasms, the neuroendocrine and the neuroendocrine tumors, acina cell carcinoma. We do not see too many pancreatoblastomas, so I do not have too much of experience of that right at this moment. We used to see pancreatoblastomas a long time back. So that is one place which I have explained in the last slide, where I showed this particular table, where you can see how it has been used. Now, there is another role of immunochemistry, and that particular role is to differentiate between pancreatic ductal adenocarcinomas and chronic pancreatitis. To be very honest, in most of the places, or most of the times, we do not need to use immuno. We are able to confidently differentiate between these two conditions, and we have been doing pretty good. But if needed, there are certain immunos which are available. Okay, so like Maspin, SP100, S100T, we can use them, but we do not use them routinely. The other place where immuno can be extremely useful is the role of INI1. Okay, whether INI1 is retained or INI1 is lost in case of anaplastic carcinoma. Yeah. So this is more or less what we can say, what I can say about the immunos in this lesion in general. Yeah.
Right, great. So we will wait for Dr. Susila's comment. In the meantime, Dr. Nabanita had commented back saying, thank you so much. It's pretty clear. There is another question by Dr. Nabanita, and she says, how tumors in body and tail of pancreas are sampled for cytology in your center?
Very good question. So, this is something which I had discussed in detail, Dr. Nadeem, if you remember, in the previous webinar. And so,
she can go back and
what
see
happens
that.
Is that the lesions in the body, in the head of the pancreas, we go through the transduodenal route. The lesions in the body and the tail of the pancreas, we go through the transgastric route. As a result of which, the problem which I had mentioned related to gastric epithelium contaminating the aspirate is more a problem with lesions in the body and the tail of the pancreas, because you are going through the transgastric route. It can also become a problem. There is one case which I wanted to show but I just left out, is that when you are going through the celiac lymph nodes, you are going high up through the body of the body of the stomach, and at that point of time you can have a lot of contaminating cells coming from the gastric epithelium, and they can really make life very difficult sometimes, admixed with lymphoid cells, to say whether you are dealing with a metastasis or whether they are just gastric epithelial cells. And it is an extremely crucial diagnosis you are making, because the moment you are saying that it involves the celiac lymph nodes, the state changes and the patient can go from an operable to an inoperable state. So yes, it is extremely important to know the route, and I would also like to request Dr. Nabanita to, if you can go back and hear the first presentation, I had spent a little bit of time in showing the contaminations based on from which particular route the sample has been aspirated.
Perfect, yeah. There's another part of the question on which he says, sir, what is gastroenteropancreatic neuroendocrine tumor, GEPNAT? G-E-P-N-E-T. Gastroenteropancreatic neuroendocrine.
Good question. Yeah, I wanted to use that phrase. You know what has happened in the 2017 WHO classification, a little bit before that, all the tumors in the pancreas and the gastrointestinal tract, right, they have been taken together, and the classification that is used for these particular tumors, okay, they follow a similar kind of process. So that is why they use a kind of a combined term to say that, so the same criteria that we are using over here can be used for tumors throughout the gastrointestinal tract. So that's why they use this this kind of phrase.
Right, and she
Yes.
adds on to that saying, I heard Steve Jobs had that GEPNET. Is it true, sir?
Yes.
Okay. So I think
Yes, he definitely had it, and after he was diagnosed, the doctors were crying with joy because they felt that because they thought it is a pancreatic ductal adenocarcinoma or more, but he had a well-differentiated pancreatic, but he didn't, I guess, go through with the surgery, and there were other things which went wrong. But yes, he definitely, this is the tumor which I believe he had, and that it is well known, it is written in his biography, the doctors cried with joy thinking that, well, it is like a new lease of life, but he didn't go ahead with the therapy, but that's not for me to talk about. Yeah.
Dr. Nabanita has a final comment saying, I'm grateful to you, sir, in spite of long webinar. Sir, you have taken up all the questions and had explained them extremely well. Very excellent webinar.
Thank you very much, Dr. Nabanita. Thanks.
I agree with her, absolutely word to word. It was a wonderful presentation, MRINMAY, as usual. And you are a wonderful teacher. The way you teach and the calm in your teaching is an expression, or you can say, of your knowledge of the subject. You are a real authority in this cytopathology lesions. Wonderful to have you on board here. Thank you so much.
Thank for doing a wonderful job, Nadeem, especially in these very, very difficult times. And I hope that you all stay safe. And it's very difficult. It's a huge challenge for all of us, but I'm sure we are all going to get through this. Thank you very much.
Yeah,
Take
thank
care.
you so much.
Good luck. Good night.
Just before we close down, let me just tell you,
Yes.
on the 5th of May, this is our next lecture is on soft tissue tumors, which is on vascular malformation and vascular tumors, to be taken by Dr. Gyud Gitanjali. She is an MD DM from PGI Chandigarh, presently in Hyderabad. And this is going to be our 150th lecture on the Pursue series.
Wow. So this is, you should raise the bat now. You have to raise your bat. Well done,
Thank you
Nadeem.
so
So
much,
proud of
Dr.
you.
Minmay. Yeah, thank you so much, everybody, for being here. Thank you so much,
Yes.
Dr. Minmay. God bless you. You are a wonderful teacher. I will request
Thank you
you to
very
come
much.
back.
Thanks.
and
And thank you for the certificates. Thank you very much for that. That was a really very nice appreciation on your behalf. Thanks a lot. Bye-bye.
It's an honor to have you people here. Thank you so much. Take care. Bye-bye. Stay safe. Good night,
Yeah.
everybody. Bye.
Sure.
Bye-bye. Bye-bye.
How is it?
Nice.
Are you done?